Okay, so today we're cracking open a case file on a fascinating medical investigation. Seriously, it's a true detective story that plays out right inside the human body. And the mystery? It all starts with a single suspicious finding, a mass in the pancreas. So, picture this. A CT scan lights up a screen. It all looks pretty normal until the radiologist freezes the image. There it is, a shadow, a little question mark deep in the abdomen. This is our crime scene. And the big question is, what is that thing? For the medical team, this moment kicks off an incredibly high-stakes investigation. A patient's life really depends on getting this right. So we're going to follow the clues piece by piece, just like they do. Right. Any good detective knows that the first step is to narrow down the field. And when you're looking at a pancreatic mass, there are really two prime suspects you have to consider right out of the gate. Think of it this way. You've got your usual suspect, ductal adenocarcinoma. This is the one you see most of the time, by far. And then you've got the much rarer characters, the neuroendocrine tumors. Now, they're both serious, but they have totally different profiles, different behaviors. They're just completely different criminals. All right, so let's zoom in on our prime suspect, the one responsible for the vast majority of these cases, adenocarcinoma. This is who the detectives are trained to look for first, every single time.
And here's why it's suspect number one. Look at that number. A staggering 95% of all pancreatic cancers are this type. The odds are just overwhelmingly stacked that this is what we're dealing with.
So let's look at the rap sheet for this one. What's its MO? Well, it typically shows up in people in their 70s or 80s, and the biggest risk factor, hands down, is smoking. It usually likes to set up shop in the head of the pancreas, and its classic calling card is painless jaundice, that yellowing of the skin and eyes. Sometimes you even see this other weird clue, migratory thrombophlebitis, which is basically recurring blood clots. Now, on the imaging, the crime scene photos, if you will, this is where investigators get their first big break. If the mass is in the pancreatic head, it's notorious for blocking two major pathways, the common bile duct and the pancreatic duct. This creates a really distinctive clue called the double duct sign, and it points right at our prime suspect. Now, this is where it gets really interesting. Think of a CT scan with contrast dye as putting the suspect under a great interrogation lamp. The healthy parts of the pancreas, they light right up, but the tumor, it doesn't. It stays dim, a hypo-enhancing mass. It's basically trying to hide in the shadows. But what if the clues just don't fit that profile? What if the suspect isn't hiding in the shadows? Well, that's when we have to turn our attention to a completely different breed of suspect, the neuroendocrine tumors. And here is their dead giveaway. Where our first suspect was dim and kind of sketchy, these tumors are what we call hypervascular. They're just packed with blood vessels. So when that contrast dye hits them under the interrogation lamp, they don't hide. No way. They light up like a beacon. It's the complete opposite behavior. Now, this family of suspects has its own little gangs. The big boss is the insulinoma, making up about 75% of the cases. Then you've got gastrinomas, and the much less common glucagonomas. And each one of these guys causes a totally different kind of trouble by releasing different hormones. So let's take the gastrinoma. It kicks off this wild chain reaction. The tumor just starts pumping out tons of a hormone called gastrin. Gastrin's job is to tell the stomach to make acid, so the stomach just goes into overdrive, creating these awful ulcers that won't heal. So in this case, the symptoms themselves become a critical clue to the culprit's identity. Okay, so just when you think you've got your two main suspects lined up, the case throws you a curveball. Sometimes the mass you're looking at isn't pancreatic cancer at all. It's an imposter, a red herring designed to throw you completely off the trail. Our first imposter is the ampullary carcinoma. And this thing is a master of disguise. It shows up right next door to the pancreas. It causes a mass. It can even cause jaundice. It looks and acts just like our prime suspect. The key difference, though, is where it comes from. And catching this imposter is huge because it usually means a much, much better prognosis for the patient. Now for what might be the most bizarre red herring of all. It's a condition called post-traumatic splenosis, and the investigation takes a sharp turn when the detectives dig deep into the patient's history and find a key clue, a history of some kind of major physical trauma, like a bad car accident years and years ago. Because here's what can happen. That all trauma can cause a tiny piece of the spleen to break off, travel, and just implant itself on the pancreas. It's not a tumor. And the giveaway clue is just incredible. On the right kind of scan, it shows up as a tiger-striped mass. It looks exactly like a normal spleen. It's not a culprit at all, it's just a bit of spleen that got lost and set up shop in the wrong neighborhood.
So after following all the clues, interviewing our suspects, and unmasking the imposters, it's time to file the final report. It's time to crack this case.
So here it is, the whole case laid out. You've got your adenocarcinoma, the common, dim, shadowy culprit. Then there's the neuroendocrine tumor, the rare, bright one that's often hormonally active. And finally, splenosis, the ultimate red herring, that tiger-striped mass with a history of trauma. Each one has its own unique fingerprint. So you might be thinking, okay, but why does all this detective work matter so much? I mean, a mass is a mass, right? Well, no, absolutely not. Correctly identifying the culprit is everything.
It's because the identity of that mass determines the entire game plan. It dictates the kind of surgery, what treatments are needed, and maybe most importantly, it gives the patient a clear, honest idea of their prognosis. Getting the diagnosis right is the single most critical step toward getting the treatment right. And that's what's so incredible, isn't it? This process of deduction, of piecing together these tiny clues from someone's history, their symptoms, and a few shadows on a screen. This happens in hospitals every single day. It kind of makes you wonder, what other medical mysteries are hiding out there in plain sight, just waiting for the right detective to crack the